Right. I was just wondering if we had everyone on the call. Welcome to this launch event for the Cheshire Merseyside Cancer Alliance Strategic Obesity Project. This is our first venture into health promotion, so we really want to welcome everyone who's taken the time to join the call today. And I'll just run through a few slides before we get straight into the presentation. So just to give you a bit of background to today's event, this is about bringing the whole system together to reduce the prevalence of being overweight and obesity. The rates of being overweight and obese are rising nationally and across our region. And it's the second largest modifiable risk for cancer next to smoking. So it's a really serious and big issue that we want to start to tackle. So we're taking a whole system approach in our region to reduce that prevalence. And if we move to the next slide, please. So the overview of today's programme, well, really it's a chance for all the delegates to understand the prevalence of this issue within our region and the association with cancers. We've got presentations both from local and national experts currently involved in addressing this problem. And we'll also hear some lived-in experiences of living with being obese, as well as the barriers that challenge people. And then we'll have a panel session looking at the wider determinants of being overweight and obese and how we take that whole systems approach. And then we'll have updates on 2 new pieces of research being carried out by the project. And then finally, a call to action for all stakeholders, all of you here, to connect together and amplify what we're trying to do across our region. Thank you. Moving on, so a little bit of housekeeping first. We have, it looks like 173 people on the call. We have more signed up, so hopefully more will join us. As I've said before, a huge thank you to joining us today. Owing to the tight schedule, we'll not be taking Q's and A's during the, between the talks, unless there's a gap. I might ask a question, but the chat box will be open, so please put those questions in there and we'll try and answer them afterwards. Just to remind you, social media people, don't forget to use the tags there for tweeting. We put them up there to make a note of them. Please note we're recording this event, and all presentations and recordings will be circulated to everyone at the end. And many thanks, of course, in advance to all our speakers. I know they're already in waiting with the exception of one, so let's hope it goes smoothly and on time. If I just lead into the introduction of our first speaker. Our first speaker is John Hayes, who I work very closely with. Many of you may know him. He's the Managing Director of the Cheshire Merseyside Cancer Alliance. Many, many years, like myself, of working in cancer. And he's going to talk to you about why obesity matters to our region. So thank John in advance and hand over to you. And of course, I'll keep you all to time. So please enjoy the sessions, and over to John.
Thank you very much, Liz, and welcome everybody. It's really, really good to see so many people on the call today. So as Liz says, I'm John Hayes. I'm the Managing Director of the Cheshire Merseyside Cancer Alliance. I'm guessing that given how many people we've got on the call today, not everybody will be familiar with the Cancer Alliance and the work that we do. So just ever so briefly, the Alliance is an organisation, part of the NHS, that oversees cancer services for our population of 2.6 million people. We're an umbrella organisation, I guess, of a sort, bringing together stakeholders such as hospital doctors, nurses, scientists, GPs in primary care, charities, voluntary organisations and local communities, and of course also patients, to drive forward improvements in cancer services and outcomes for patients. So much of our work focuses upon improving pathways of care for people being investigated for possible cancer, being treated for known cancers, or being supported following their treatment. And a huge amount of our work goes into ensuring patients have good access to great NHS services, and benefit from modern diagnostic techniques and evidence-based treatments. So improving patients' experience of cancer services and ensuring that patients get the best possible chance to live well following treatment are both really, really key. But we also have another really massively important objective, and that's to do all we can collectively to prevent cancer from occurring in the first place. So that brings us to the purpose of today. I'll just expand these. I think that's the last one. Okay. So there are some key facts on this slide, and I guess the big question is, why is the Cancer Alliance focusing on overweight and obesity? And I think some of these facts show us exactly why we should be focusing on these. And I'm sure that Malcolm, Ian, Philippa, and others during the course of this afternoon will share with you more data in their presentations too. So just some headlines. Obesity is on the rise and will affect more than 21 people in the UK within the next 2 decades. As Liz has already mentioned, obesity is implicated in the occurrence of many cancers, including common cancers such as breast and colorectal, and it is the biggest modifiable risk factor after smoking. Furthermore, here in Cheshire Merseyside, we have a higher incidence of overweight and obesity, including in our children and young people. So it's significantly higher in some cases than the national average. And of course, we have higher rates of cancer incidence and mortality too. So it really matters. It is important. We're also fully aware that there are many people already working in many organisations on reducing overweight and obesity. And this really isn't anything new. We're not here to duplicate or tread on anybody's toes. What we're trying to do, though, through this project is to join the dots, to connect people and projects to increase the overall volume and reach of initiatives. And we're delighted to be working with the Health Equities Group, who are experts in this field, to make all of this happen. So just to start the afternoon off, just a few reflections from me. The government's recent decision to delay a key part of its obesity strategy, namely curbs on multi-buy deals, and advertisements for junk food, has been widely criticised. And then last month, the government published its long-awaited food strategy following a comprehensive review by the restaurateur Henry Dimbleby. But many people have criticised the food strategy for being weak and lacking ambition, and Mr. Dimbleby himself said that he was disappointed to see that the government had only taken on board about half of his recommendations. His recommendations for salt and sugar taxes were missing from the white paper, the extension of free school meals was missing, and there's no mention of minimum standards for food trade deals, meaning that farmers potentially face a future of competing with imports from countries with lower food standards. So I don't think, in the light of those recent examples, that we can sit back and rely purely on national policies or strategies to address obesity and poor diets. No matter how well-intentioned those national exercises start out, they frequently get watered down by relentless lobbying from powerful businesses and self-interested industries. So, Cheshire Merseyside, the goal that has been laid down, it's up to us, I guess. We need to work together with members of our communities, local groups, businesses, to make the connections, amplify each other's efforts, and design new strategies together. And I think really right now is a great time to launch this project for many reasons, but I'll highlight just 2. I'm sure that many of you will have heard of Sir Michael Marmot. I don't really have many heroes in life, but he's definitely one. He's a bit like the Sir David Attenborough of the public health world. So Michael founded the Institution of Health Equity at UCL, and then back in 2010, you'll probably remember he published a groundbreaking report on health inequalities in England. And that report set out exactly where inequity existed and really quite clearly spelled out what we needed to do about it. And then 10 years later on, in 2020, he published another report that showed, unfortunately, no progress had been made in the course of that decade. Improvements in life expectancy had stalled, and the average number of years that people spent in poor health had actually increased. And most damningly, probably, the report showed that health inequalities had widened, with those living in the most deprived neighbourhoods experiencing greater inequality than they did 10 years ago. So Michael and his team at UCL have just actually published a fantastic new report looking specifically at health inequalities in Cheshire and Merseyside. And critically, it's not just a report that's going to sit on the shelf. There's a whole community of stakeholders who have signed up to working together and have committed to following through the recommendations of this new report at pace. This programme of work that we're here to talk about today, I think fits perfectly alongside that new commitment. I can highly recommend watching Sir Michael's presentation of the launch event of the Cheshire Merseyside report, actually. It's still on the CHAMPS Public Health Network website. I think if you just give it a quick Google, it should come up. And I think if you scroll into about 30 minutes into the launch event, you'll find Sir Michael doing this presentation. It really is compulsive watching, I think. The second opportunity, I think, is also brand new. There's just been a major reorganisation of how health and care is planned and delivered, with the creation of a new statutory body, or Integrated Care Board, replacing CCGs, and just as importantly, a new integrated care partnership covering the whole of Cheshire and Merseyside. The board and the partnership particularly should help to enable all parts of the system, whether it's the NHS, local authorities, voluntary sectors, local businesses, etc., to work together to tackle the social determinants of health. It's early days. The new structures only came into effect on the 1st of July, but let's see it as an opportunity to have more joined up conversations. Dave Sweeney might expand on some of this later when he takes to the podium. So I'll wrap up there. I just want to quickly thank my colleague in the Alliance, Steve Jones, for his hard work and vision, which have really got us to this point, working with the Health Equity Group. So thank you, Steve. And I'm really looking forward to the rest of the day and really excited about working with, hopefully, many of you over the course of the next year. Thank you very much. Thanks, Liz.
Thanks, John, and well done for giving us a few minutes slack in the day already. So, just to fill for a few minutes, I think the key messages for me there was, obviously we've got higher levels of obesity and some cancers in our region, so it's an even bigger problem for our region than the rest of England. I think the other bit was that the national strategy may not be enough, so we need to do more, and even more reason for us to do more. I like the Sir Michael Marmot, he's my hero, and I saw a little bit in the chat that he was other people's hero as well. And he's obviously done an amazing job at bringing people together and getting momentum behind inequalities. And then I think the last thing I heard were the really good opportunities that are ahead of us with the change in architecture of health and social care and bringing people together much more closely. So if you were to ask me as a chief executive of a cancer hospital, would I be sitting here talking about obesity and prevention some years ago? Absolutely not. But it's clearly on our agenda now, and we have a responsibility to our public as healthcare people to make a contribution towards preventing people from having cancer in the future, as well as treating the here and now. So I've filled in a few minutes, but hopefully our next speaker is ready, and I'd like to introduce you to Malcolm Clark, who's Senior Prevention Policy Manager for CR UK. And welcome, Malcolm. Thanks to John, and you've got a couple of minutes extra thanks to John as well. So over to you, Malcolm. Thank you.
Thank you. Can I just check that you can hear me, Liz?
Yes, I can. Thank you.
Good. That's brilliant. Thanks. Hi, thank you for inviting me here to talk to everybody, and I say congratulations to the Cheshire and Merseyside, the Cancer Alliance, for sort of initiating this project and partnership, and also to Health Equalities Group and Food Active, who I've enjoyed kind of a long working relationship with over I say pretty much the past decade almost, and I say have had highlights including, I say, both successful policy influencing and campaigning, but also highlights including dressing up as tooth fairies and handing out campaign literature outside the Labour Party conference in Liverpool, encouraging MPs and other Labour Party officials to support a sugary drinks tax. So I say a nice relationship up in the Northwest. Really pleased to continue that today. So I am just making sure I can control the slide deck. So just bear with me. Okay, there we go. Brilliant. So today I wanted to, I guess, talk a little bit about, I say, the reminder of, I said, the size of the prize, why Cancer Research UK is interested in this topic of overweight and obesity, and why it's important. And we've already heard a couple of stats already on that. I want to talk about our work, the research that we published a couple of months ago, projecting overweight and obesity rates forwards by sort of almost 20 years, and what those stats showed and why we did that. Looking, if we don't get too depressed, at the current state of play with obesity policy, but then also, I say, looking ahead to what we can do to, I say, particularly on a national stage, to support the work that goes on locally and regionally, but also what can we do locally as well. But I know that is being covered much more in other presentations. So as has already been said, kind of almost 4 in 10 cancer cases, I say, can be prevented, and that obesity or keeping a healthy weight is the second best way of preventing cancer. It's the second biggest preventable cause of cancer here in the UK, after tobacco, after smoking. You can see the smoking sort of area is, circle is quite a bit bigger than everything else. It is very clearly, certainly at the moment as things still stand, the #1 cause of cancer, and Cancer Research UK has actually just started launched a new campaign last week, looking at how we can push the UK to be smoke-free, and look at what population-wide policies can be done to support that. But we also have been, and our work is very much over the last 5 years or so been focused around strategically those two biggest preventable causes of cancer: tobacco and obesity. And so here's a sample of some of the work that we have done in the past. We've looked at raising awareness of the link between overweight and obesity and cancer, and these were kind of, we did both a nationwide sort of health marketing campaign, and also one that was more targeted towards MPs and decision makers in Westminster. And then we also, we've also done campaigning and influencing as well around junk food marketing campaign, looking at particularly around restrictions on high fat, salt, sugar marketing, advertising and promotions restrictions. And I'll come back to that later in the presentation about where we are with it. But we've had a population-wide approach, but in the last few years, we've also particularly been focusing on trying to better understand and explore cancer inequalities, and the fact that particularly there are 30,000 extra cases of cancer attributable to socioeconomic deprivation each year, over 30,000 new cancer cases each year directly attributable to socioeconomic deprivation. And we know that people in the more deprived groups have a much higher mortality rate in England and a lower survival rate. So this is something that matters to us, is looking at ways to address inequalities. And one of the things that we did a year ago was just look at try and drill a bit more down into looking at overweight and obesity by deprivation, and recognizing kind of in the stats that the research that we did, that particularly it was deprived female populations have a higher proportion of overweight and obese attributable cancer cases compared to less deprived female populations. So I say it was about, that rate was about between 10 and 29% higher in the most deprived UK women versus the least deprived, and that gap wasn't so noticeable amongst men. It was still there, but significantly smaller. So again, kind of in terms of where we know that more work needs to be done, and policy and attention focus, that's obviously one thing, is addressing that aspect. But more recently, I say just in May, what we wanted to do was to look at, I say, projections for the UK and for the individual constituent nations of the UK, looking at, we know that overweight and obesity prevalence is among the highest in Europe. We know it's increased markedly in recent decades. And we know that while the prevalence rates appear to have plateaued in recent years, it shows no signs of declining. So what we wanted to do is to understand what, we know that projections and the prevalence of overweight and obesity is necessary to indicate the scale of demands that our health service can face in the future. I believe, just looking at that, I believe the slides will be shared, so don't, I say you don't need to frantically copy lots of stats, so don't worry on that. So we know that if we look at the scale of demands on a health system, we want to know what's happening in the future, and we want to be able to use projections to, I say, focus the minds of decision makers and relevant bodies and look at what needs to be done. So we did this piece of work where, I say, looking at the trends, and I say the headline figure, my thunder's already been stolen, but was exactly that in terms of kind of the projection from 2019, where there are 64% of adult UK men and women. The prevalence in the UK was going to be 64%. It would rise to 71% by 2040, equating to over 42 million more people who would be overweight or obese. And so looking at those numbers, it's about similar amounts of extra people who would be overweight and living with overweight, and a similar 21 million living with obesity. And if we drill down a little bit further, I mean, you can see here what I've been talking about, the sort of plateauing in the last decade, and then the rise overall on the right of the screen from 2020 onwards, looking at the projections for the next 20 years through to 2040. And we can see that, I say, if we look at specifically at those who are overweight, those living with overweight, you would the projections would be that I say it's seeing very slight falls in the, I guess, the percentage of the population, and who live with overweight, and there would be I say, but you can see that the men is still, the rate is still significantly higher than women in this one. I should say these stats are for England as a whole. And if you look at obesity prevalence, you can see that the rate would be rising, and there is actually a convergence in terms of the numbers of men and women living with obesity projected through to 2040, where there is a slight gap now. It would be pretty similar now and rising. And though I don't have the table, if we were to look at severe obesity, certainly looking at obesity, we would see that there will be more people who are obese compared to people who are a healthy weight in the UK by 2040, making obesity the most common BMI status. And again, severe obesity prevalence would almost double from 3% now to almost 6% in 2040. And then if we looked at the projections in terms of deprivation, again, you're seeing some very significant, I'll say there's divergence already, but an even greater divergence, particularly amongst the trends of the most deprived compared to the least deprived in this. And I say we would project that, I was just trying to get the right stat. The deprivation gap for obesity between the least and the most deprived groups projected to increase by more than half in England and Scotland by 2040. So the gap starting between 2020 and 2040 expected to grow by almost half in that period. So these are quite significant, I say, projections, and I say depressing in a way. Quite rightly picked up, some of these big stats were picked up by the press when we released the report in May, and got some good headlines, some good interviews. But we weren't actually doing this just for the press coverage. We were doing it partly because only a few days beforehand, I mean, we'd obviously been preparing this report for a while, but only a few days beforehand, the government had announced that it would be delaying the restrictions on junk food advertising and on price promotions, each by a year. And considering that they'd only just passed the legislation for the junk food advertising, this was quite surprising and obviously incredibly disappointing. So we wanted to kind of cause some noise to make those decision makers think again about what they about these delays, and I say that was the context that we put this out. And looking at that kind of population-wide kind of UK government action, we have we did have quite a positive action from this government, and from previous governments in terms of a childhood obesity strategy and commitments to legislate on junk food advertising, promotions and other aspects. If we look at what's actually happened, the out-of-home calorie labelling is the only thing that has actually come in so far. Mandatory out-of-home calorie labelling, the restrictions ending location promotions of high fat, salt, sugar food and drink in supermarkets is due to come in October. So the legislation is there. So far nothing is stopping it, so hopefully that will come in as planned. But unfortunately the other buy one get one free volume-based price promotions are coming, have been delayed by a year, and so has the advertising. And what I would say is kind of these were evidence-based measures, which I say I won't go into the evidence-based because of time, but is that particularly say on all of these, the evidence is that they were pushing say consumers, families, children to buy and to choose higher calorie, higher sugar products, and to consume more of them and more often, and to consume less fruit and veg and less fewer healthier options. So that was why I say I completely agree that there is space for promoting ensuring that healthier options are directly promoted, and in a sense this was about giving the space for on shelf, online, and in other spaces for those healthier options to be done. I'm not going to kind of dwell on the specifics of those actions, but I would just say kind of why it was important to us as Cancer Research UK to be supporting the calls for these policy actions was precisely because the world around us affects how healthy we are, and there were a whole series of things that affect that, and as part of that, promotions, advertising, labeling are all part of the things, as well as wider health marketing support from health professionals and other aspects that we'll come on to in the whole systems approach. So just kind of the political situation is obviously very fluid at the moment, and there's not a whole lot being said about health and population health so far in the and certainly in preventative health so far in this Tory leadership election, and measures such as the Health Disparities White Paper that were due to at least flag some ideas and some potential progress on some of the things we care about. That was, that white paper from government has been delayed, so things are kind of on the back burner. But what we do have through the Obesity Health Alliance, which is an alliance bringing together 40+ different organisations working on trying to reduce overweight and obesity. The Obesity Health Alliance has done a sort of evidence-based healthy weight strategy called Turning the Tide. It's kind of a year or more to produce, and that very much was about what can be done to meet the government's own 2030 target for halving childhood obesity, and also looking across the life course. It looked at what was practical and achievable. It expressly looked at how to minimize and reverse weight stigma, and it looked at kind of how to improve the policy making process as well as just the policies themselves. And so I'd thoroughly recommend kind of people do look on the Obesity Health Alliance's website and dip into certainly the kind of 2 or 3 page summary or the executive, slightly longer executive summary. But that had a whole series of different policy ideas, some that we should keep, things that are happening already that need to be either done more of or implemented, things that intensifying existing policies, new proposals, and developing policies in new areas, or looking at new research to see what else should be done. And so again, there was a whole series of different measures for to improve the environment, and it wasn't that these are the on this slide is just the I guess the more environmental focused recommendations, but there were others around the NHS and school settings, or school and education and other settings as well. So that's I say there are a whole series of kind of evidence-led evidence-based measures recommended, and kind of this framework for action, and I think that's really helpful to help guide kind of population-wide measures for what we want, not just of this government or the immediate next government, but what we're trying to push over the next 5 to 10 years, because we know that the for here, the path to policy success is rarely straightforward. I think that's a minor understatement, and there are so many highs, lows, false dawns, and frustrating moments in trying to get policy change. And we know that I said things need to change. Behaviour change needs to happen, but you need that policy change to support that wider, better environment for people. We know it's not straightforward. we know particularly at the moment it's not, and I say so Cancer Research UK I say will continue to have a role in helping to influence obesity policy, whether that's through our own contacts with stakeholders and government officials, whether it's through contributing and amplifying the great work of the Obesity Health Alliance, whether it's through further research that we fund, either that we do directly in-house or particularly on the science side, better understanding some of the biological the biological understanding of how overweight and obesity leads to or increases the risk of cancer and of particular cancers. There's more. That is part of our new sort of 10-year research and innovation strategy, is looking at that from the obesity side. But we also have a network of ambassadors and cancer champions on the ground across the country, people who volunteered to help spread our work, to help talk with local influencers. And I guess that's where so I just wanted to kind of leave it with just mentioning, I say, one part, which is that we have a local public affairs team at Cancer Research UK, and that's particularly at the moment working with metro mayors across the 10 mayoral combined authorities to influence policy and support cancer prevention, screening and early diagnosis. I say, we know that Greater Manchester is the only region at the moment which has the devolved powers for public health, but our engagement, I say, has ranges more than that, and we certainly we look at both tobacco and obesity, and what policy calls around regional smoke-free targets, supporting regions to implement junk food advertising restrictions, and also calling for a healthy workforce charter. So I know that these are some of the things that we have. Say a small amount of capacity internally in Cancer Research UK to continue to work with. And I think my colleague Kadisha may even be on this call as well. Kadisha, sorry if I've mispronounced her name. Kadisha is on the call as well, and really interested in the work that this being able to support the work that this new project is doing. So I will leave that there. I hope that's been a useful introduction into, I guess, the wider population-wide approach to reducing overweight and obesity.
Thank you, Malcolm. And I think it's so great that CRUK is dealing with this at a policy level, because your influence is excellent with them. I know you put up your squiggly lines, but people listen to CRUK. And I think it's so important that you're trying to influence policy, and also do further research into the links between obesity and cancer. So a totally different presentation now. We're really mixing it up today. And thanks to Malcolm, but welcome to Angela Chesworth, who's our patient advocate today, and she's going to talk about obesity through a different lens. So over to you, Angela. We look forward to hearing your story. Thank you.
Thank you, Liz. Hello, my name is Angela Chesworth, and I'm a person living with obesity. I would like to share with you just some of my lived experiences, in the hope that you may just see obesity through a different lens. Can I just bear with me 1 minute? I can't seem to get the screen to change. Nope. There you go. Okay, thank you. I have struggled with my ever-increasing weight from childhood. Many years of diets. I would lose the pounds only to regain them and more over time. What was I doing wrong? Why can I not maintain my weight? I'm such a failure. I need to try harder. My heaviest weight to date has been 24 stone. In 2013, I received bariatric surgery, a gastric bypass, I lost 12 stone in my first year. 8 years post-surgery and 2 stone regain, today I am maintaining a 10 stone weight loss. No high blood pressure, no obstructive sleep apnea. I am far healthier and happier. However, I still live in fear that I will one day return to my heaviest weight. I would like to ask you some questions today. I don't want you to answer, they are purely things for you to think about. Do you have a mother or father, sister or brother, a partner, a best friend or a neighbour who is overweight or living with obesity? Have you ever made fun of a person because of their body size? Have you ever shared a funny picture on social media, commented to a friend on how the big person is dressed, joined in with a group of friends who are making "who ate all the pie" jokes, rolled your eyes because you're sat next to the only empty seat on the bus, knowing that they are coming your way, looked into a person's shopping trolley in a supermarket and thought, well, no wonder they're big. Well, the person living with obesity who is in your life sees this judgment. They hear the laughter, they feel the disgust, every single one of us, including the people that you know. So today, I would like to invite you to put yourself in the patient's shoes. As a person living with obesity from childhood, I have spent my life carrying my obesity like a bag for everyone to see and judge. I carry the bag of worthlessness. At the age of 10, I was being physically and mentally abused every single day by a classmate. I would have to give her a chocolate bar and 20 pence or she would beat me up. She would tell me, it's for your own good, I'm stopping you getting fatter. I never told anybody because she was right. I was fat and they would agree with her. My mother stopped giving me pocket money as part of my diet plan, so I turned to theft. I would steal milk from our neighbour's doorstep so I could keep the money my mother had given me to buy the milk, just so my bully wouldn't hit me. If I had no money, I would drink vinegar and put my fingers down my throat to make myself vomit so I didn't have to go to school. After a number of years, I couldn't take any more. Something inside me snapped. I picked up a brick and hit her in the face, breaking her nose. I was expelled from school with the incident on my record. At the age of 10, I had become a thug, a thief, and a liar, all because of how I was treated due to the body I lived in. I look back and wonder if I would have done better in school if I had been free to focus on learning instead of worrying about being beaten up. I think how lucky I was I only had one bully. Today's children have social media pressure as well as face-to-face. I spent my childhood believing I was worthless because I wasn't normal. I carry a bag of failure. As an adult, I've been spat at in the street. I've been verbally abused whilst working out in a gym. I've been refused promotion because I wasn't the right image, even though I have been doing the job for over a year. I've been told by strangers I should go away and die, just so someone who's genuinely sick could get help. I've spent 30 plus years feeling a failure, and I still struggle with those feelings today. I would work a 12-hour shift in a supermarket, doing a physical job, filling the shelves, all fueled by a salad. I would clock off and go to the gym, a 1-hour session with a personal trainer, followed by 1-hour swim. Nobody sees that. They just see my body size and make a judgment. All I've ever been told by my healthcare professionals, TV, media, governments, society, friends, family, and my own internal thoughts is to eat less and move more. Comments like, you have done this to yourself. You need to stop eating. Only you can change. You have no willpower. You need to try harder. This list is endless. Why could I not control my weight? Why am I such a failure? I carry a bag of shame. I attended a general practitioner's appointment as I had an ingrowing toenail. I was told, and I quote, "You need to go away and come back when you're not so fat." No treatment, no constructive advice, just humiliation and shame. Discreetly asking the flight attendant for a seatbelt extension on a plane, only to have her shout whilst waving the extension, "Who doesn't fit the seatbelt?" Being asked to wait outside the dentist's waiting room because I'm a fire hazard blocking the door. Unable to try clothes on in a fitting room because I can't turn round in the cubicle, let alone bend down. Having to ask other diners in a restaurant to lift their drinks off the table in case my thighs would knock them over as I maneuver between the tightly spaced tables on my way to the bathroom. Then the thought, oh no, I have to go back. Being asked to dance by a good-looking man in a nightclub, only to be laughed at, realising he won the day, dancing with the fat bird. The bag of shame overflows on a daily basis. I will carry a bag of anxiety, waiting for a bus and hoping the bus isn't full. If I stand, I will block the aisle. How will others get off? What do I do if there is an empty seat, but the person next to it rolls their eyes in disgust as I walk towards it? That split second as the bus pulls up and you see how busy it is and how many people are getting on. Do I wait for the next one or step on to travel in torture? Everywhere I look, I'm told as a person living with obesity, I should exercise. However, if something causes you pain and anxiety, it's difficult to keep doing it. Physical pain you can work through, but it's not so easy if it's mental. When I went to the gym, I was confronted by another member asking, should you really be sweating that much? Make sure you wipe the seat because I don't want to sit in your sweat. If I went to the local park, I would get kids making fun of me, shouting, "Hey, fatty." Well, that's the polite version. I get adults pointing and laughing if I'm using the gym equipment. So I would only go if the weather was bad because it would be quiet. I carry the bag of fear. I love swimming, but when you receive comments like, "Don't jump in, the water will jump out," or "Are you wearing a skirt to hide your wobbly legs?" Socially, everything focuses around food. If we're celebrating, let's go out for a meal. If we're upset, let's go out for a meal. Visiting a friend, let's take them some chocolates. We haven't seen our friend for a while, let's send them some cupcakes. Christmas, Valentine's Day, Easter, birthdays, anniversaries, Pancake Day, Halloween, advert after advert after advert, food is everywhere. There are many bags to carry as a person living with obesity, not only physically, but mentally. Some days it's hard for me to see the world, but what's more damaging is the world doesn't see me. The mental health aspect of living with obesity has been the most challenging for me. I've been extremely lucky. I received 18 months cognitive behavioural therapy, which I believe is a huge part of how I am still alive today. Bariatric surgery was a treatment for my body. CBT is a treatment for my brain. At one point, I thought my only way out was a bottle of vodka and as many paracetamol as I could get. To this day, I don't know what stopped me from taking them. The hardest part of living with obesity is people's judgment. At 24 stone, nobody's seen Angela. They just seen fat and felt they had the right to judge and ridicule. I'm seen differently now, but I'm still the same person. For example, at a recent weight management clinic checkup, I was sent for annual blood tests. The nurse taking the bloods apologised to me for waiting and continued to say, and I quote, "The fat clinic are in today and they take up so much time. It's so much harder to get the blood out of them. The nurse had not realised I was attending the fat clinic because she was seeing me as a normal weight. Since maintaining my weight, I've witnessed so many more examples of weight stigma and bias simply because people don't know my history. It's heartbreaking. Volunteering as an obesity patient advocate, I've been educated to the complexities of obesity and the scientific evidence that proves up to 70% of a person's weight is determined by their genetics, just like the colour of our eyes, the colour of our hair, and the size of our feet. I needed more than eat less, move more. I needed the intervention of bariatric surgery as a treatment. I needed psychological support to unravel the damage years of weight stigma and bias has done to me. I needed a combination of lifestyle change, education, pharmacotherapy, and surgical treatments and mental health support to improve my long-term health. Most of all, I need people in society, healthcare, governments, media, family, and friends to see me as a person, not just my obesity. We need to change the narrative. We need to listen to the scientific evidence, and we need to stop weight stigma and bias. Obesity is a complex, chronic, multifactorial, relapsing condition. It's not just about what I eat and how I move. Having heard some of my experiences, do you think I would choose to live the life I have? Obesity is not a choice. Today, I hope I have assisted you to see obesity from a different perspective. As humans, we all need to take responsibility for our health. I truly do believe to eat healthy and be active will help everybody live a happy and healthier life, no matter what body you live in. I would like to leave you with one last experience. My first ever smear test, I was asked to lay on the floor as I was too big for the examination table. I felt so humiliated. It took 20 years before I returned for my second ever test. I was so ashamed of my body. This could have been life-threatening. We all know diagnosis of illnesses early gives a greater chance of survival. But if something hurts you, you don't do it again. I'm thankful I was lucky, and 20 years of not being checked didn't end in serious health complications. So today I would like to ask you all to remember that we are all individuals with different struggles, and what works for one person may not achieve the same results for others. So when you next see a person living with obesity, please see the person. Thank you.
Thank you so much, Angela. I saw lots of chat there. Everyone found that really powerful. Lots of admiration for your bravery, for speaking up and being so honest about your life of living with being obese and your journey and the impact on your life. It was truly inspiring, and I think the stigma cannot be underestimated, and that was very powerful. And how cruel people can be actually was another piece for me. And I hope that you get out of today, I hope we give you something back today that shows that we're going to approach this with a spirit of helpfulness and not one of blame. But I'll stop there, and huge thanks, Angela, to you. It was very amazing that you came forward for this event. So I'll hand over again to something entirely different now, and I'll introduce Robin Ireland, who's the Director of Research in the Health Equalities Group, and he'll talk to us about giving us insight into the whole systems approach. So over to you, Robin. Thank you.
Thanks very much, Liz. Just waiting for myself to come up on screen. Or maybe I don't see myself. Can you hear me?
Yes, we can.
Thank you very much. Okay, that's great. And thank you, Angela, as well. So the idea of this research was, as it says on the screen, to get an insight into people's views on taking a whole systems approach to overweight and obesity. I undertook 17 interviews with key stakeholders online in May and June. Out of those, I talked to 4 people nationally, 4 people from Cheshire and Merseyside Cancer Alliance, and 9 regional stakeholders. They were recorded semi-structured interviews. And this report, there's a full report, and all the slides are taken from this. There's a whole series of quotations. They're all taken from the report. This will be circulated sometime after the event today. So again, you don't need to write anything down particularly, and you will be able to get to see them properly. I think it's really important to thank everybody who took part in this research as well. I know some of the people who I interviewed are taking part in the event today. So thank you ever so much for your time. I think it's worth saying, I was talking to senior people, and on average, I was getting 41 minutes per interview. That's a lot of time. And I think it perhaps shows the commitment to this project. And what you'll see is some very brief analysis from the transcripts. My apologies if I've got anything wrong. The people who are involved, obviously you've got a chance to come back on it as well. But it was my overview on the interviews and the transcripts that I received. I'm not going to go through every slide in great detail because I am mindful of time, but there were topic guides. The questions were slightly different according to who I was talking to, and if they really want to talk about something specifically, that's what we talked about. I think probably the most important questions were the last 3. Most people got asked in some way or another. Do you understand the systems-led approach to the prevention of overweight and obesity? There's an awful lot of jargon sometimes in the work that we do, so it's important to know what we mean by that. How do you think your organisation can help address the issue? That's probably one of the most important questions. And who should be involved? So that's the sort of type of thing that this research tried to cover. But I sort of wanted to start in terms of sort of thanking people, which I've already done, but to make the point, there's a great willingness from senior leaders to seek to work together and use the data and networks we have to address overweight and obesity. I should also stress, and I'll say it at the end, this is only the start of the research. We will certainly be talking to a much wider group of stakeholders as well, but we thought it was important, given that the organisations have come together with the Cancer Alliance, to talk to them initially. But obviously, as we've already seen with the presentation of Angela, it's incredibly important to people to speak to people with lived experience and to talk more into community organisations as well. So that will be the next stage, if you like, of the research. So if we want to address overweight and obesity, the big question how we can do this, and we've already heard from several speakers, from Malcolm, from John. It's not easy, is it? We had that wiggly diagram from Malcolm, and people I've noticed on the chat have reminded us of the Foresight report that came out several years ago. It's incredibly complicated. So what can we do on a Cheshire and Merseyside footprint? This is what the headings of the report look like. There are the findings there, and you can see there's quite a lot of points there about what are we going to do. And also, and again, mindful of the last presentation, how do we communicate the message? How do we get the language right without stigmatizing people? And how do we get people involved? So I'm not necessarily going to read all the quotations out. I'll see how the time goes. I may, and you'll see initials after everybody's name. In some cases, I'll say who they are, but in the full report, everybody's identified, obviously. So, defining the burden, we talked about it. If the obesity epidemic isn't, it's one of the main challenges of the 21st century. And the fact that obesity is quadrupled and the distribution curve in the population shifted dramatically to the right in the last 30 years is telling us that the reason for the recent change is primarily environmental. We live in an environment that encourages us to live with overweight and obesity. And it's the norm. 2/3 of our adults are living with overweight or obesity. It's the normal situation now in our communities. So what is a systems-led approach? I'm going to quote SJ, which is Steve Jones on the first one, because I quite like this. So the whole systems approach is about how we bring together not only bits of the health service, which might be obvious, or activities around diet and activity, but also the rest of the system. So employment, housing, cycle lanes, clean air, lamp posts, just all the myriad factors that actually create an environment which somebody can consider and prioritize better health choices. Steve, lamp posts, because this is how everything connects. We need better lighting so people feel safer to go out in the evening, to walk in their parks. It's all connected. That's what assistance approaches. But also critically, what we don't understand so well, and Malcolm talked about national policy, is how it happens and how we join up policies and practice both at national level, and people have been saying this on chat as well, and at regional and local levels. Data is incredibly important. And I think everybody I interviewed more or less mentioned data in some form or another. So it's about both making sure that we're gathering the appropriate data, but also making sure that they overlay. We're not all collecting the same data, for instance, but data from a housing association is going to be very different from the NHS, or going to be very different from transport, it's going to be very different from local authority. There's an awful lot we can learn if we bring them together. So I think we've got to come together, not just as a group of experts, but everyone in that inner system. If you can map that system from across all the sectors, but take it at a community level. And who should be involved? Well, everyone would be the answer. That's the issue, isn't it? It's not a health issue, or it is a health issue, but the solutions are outside of health, and that's incredibly important. And from my perspective, it's a pleasure seeing the Cancer Alliance leading this, but of course, primarily the situations to addressing overweight and obesity are outside of health. I think we've got to come together, not just as a group of experts, but everyone in that inner system. If you can map that system from all across the sectors, but take it at a community level. And when I'm thinking the whole system, I mean the whole system. I think there's a role to play for nearly any organisation of any scale, and I mean down to and including the family and individuals themselves. So what are we going to do? The big question. So addressing what gets called the wider determinants of health. We've taken ourselves on a bit of a journey. We are now very, very clear that we need to lift our heads up a bit. And rather than focusing on the more traditional NHS areas of health inequalities, that is a point of access into the health services, we need to be supporting improvement upstream. So social determinants of health. If we just approach overweight and obesity as a purely mechanistic engaging with a person who's already overweight and obese, we won't actually solve the underpinning issues as to how we got there in the first place. So what are we going to do? Working at local level within systems. It's incredibly important, and a lot of people said this, and rightly, that we need to link in all the other bits of work that are going on across Cheshire and Merseyside and beyond. It can't be about duplication. It's how it fits into the work that's already happening to enhance it and bolster it. So it needs to be all, it needs to feel like it's all joined up. And one of the most useful things, and this is coming back to communicating the message, which we'll get to later on as well, it isn't just about perhaps to the public, it's also to partners. What do we want the stakeholders and partners to do? How are we going to address overweight and obesity? And then what parts do people play? And we need to think so much more broadly. So an example here about spatial planning or housing, investment, transport. We need all these issues plugged in to consider the impact upon overweight and obesity, our obesogenic environment from the beginning. We shouldn't be building, for instance, new housing if you haven't got access to transport or shopping, for example. The role of the voluntary sector is incredibly important, and again came up a lot. So the voluntary sector is just so important in the way we work, because I think actually a lot of the time they're the heart of the community. They're a lot more plugged in than a lot of services are, because they never leave, do they? The people are in the heart of the community. I think we should be hearing from them, local community groups, what their challenges are, what their community's views are, and what their community's barriers are to having more healthier lifestyles, and what opportunities they see that can come up with as well. And this is particularly powerful, this last quote. The most powerful person in some of those communities is the next door neighbour. The fellow down the street, what we call community influencers. We need those people to start telling the truth, our little community influencers. The lady who works in the corner shop. We need that kind of, I think we need to go granular, grassroots with this stuff. What are we going to do? And we almost have to work at focus in some way. A lot of discussion over where the focus should be. Matt Fagg, from a national perspective, there is good evidence that if you want to prevent childhood obesity, you need to act before the age of 5. So reception or pre-reception. Essentially, if you haven't sorted out obesity with the age of 5, you're not going to prevent it. That's a fairly sobering thought. But clearly, early years came up quite a bit. Also, large employers. What can large employers do? And the NHS itself is a classic example, because so many nursing staff, for example, are living with obesity themselves. Learning from good practice. This came up. We shouldn't reinvent the wheel. Tobacco control came up quite a lot, and of course, as we know, smoking is still the lead factor for cancer with people living with overweight and obesity. That's going to be coming up fast in terms of the biggest factor in terms of what we can change. So, what can we learn from tobacco control? Are there other campaigns we can look at? Skin cancer in Australia, for example. There are different approaches, and it's important we do look out there. And obviously, and I think incredibly important from Angela's very powerful presentation before, how do we support people living with overweight and obesity? And I was struck by all sorts of Angela's presentations, which I have seen before. It doesn't get any less powerful, Angela. What her experience when she went to a GP, but let's put it in the eyes of the GP as well, Andy McAlevey, who said he's been a GP in Ellesmere Port for a large number of years, and he says people don't come and self-present, and it's hardly surprising if they get. I'm sure Andy works incredibly well with people, but if your GP just says, yeah, you need to lose some weight and that's not really going to be very helpful. So people don't present themselves, which is an incredibly important issue. And I guess incredibly important point again that came up from the last presentation. This is from Louise Gittins, the leader of the council in Cheshire West and Chester. I'm very much about working with people with lived experience to come up with the ways that we do things. So that takes us nicely on to communicating the message, which is incredibly important. I keep saying incredibly important, don't I? Because it is. I really think we need to reframe this as not prevention, because equally that's an equally problematic word, but making it much more about, what we're doing these things to help people be healthier, not because it's going to help people with obesity lose weight, but a lot of it, is not about weight management. It's about prevention of obesity in the first place. So I do think there's a massive reframe that we need to do. I know there needs to be a wider engagement and actually involve people and politicians and councillors and the wider public. What is it that we need to do to support this, and how do we strengthen? And again, very powerful from Joe Trask, last quote here from the Cancer Alliance itself. Mistrusting of large organisations, distrustful of education and government and health. So you have to get to those communities by word of mouth, by local people. That's kind of quite resonant for where we are in the country at the moment to a certain extent, without being political with a big P. So conclusions and next steps. There's a section of this in the full report. This is more about conclusions, and the next steps bit in the full report does talk about further research. But nothing that this country has done has got us off the worst step in Europe. So we've got to do something fundamentally different and far braver and more expansive. And that is, being more honest and talking with our public, a lot more clearly, a lot more succinctly, but with messages they're prepared to receive in a format they're going to get. If we're really looking to change this, how do you work in communities as a two-way discussion? Because what we're very good at is telling people, well, sometimes we're not very good at that, but we'll tell people what we want from them. But actually, some of the better discussions are open to what they might want from us. So creating that two-way discussion, I think, is, to me, part of the value. Thanks for that quote, Bronwyn. So I've got 2 more slides left. This, you'll be pleased. And this is a quotation from yourself, Liz. I found that this research, this insight work was very positive. People were very committed, really wanted to make a difference. Of course, we don't have the answers, but we want to work together. So cancer will not be eradicated through this program, but what we could do is prolong life and give a healthier life and a more fulfilled life and a legacy of life that can be passed on to your children and grandchildren, so that these little children see their parents looking after their health exercising, getting fresh air, losing a couple of stone, and generally feeling really good about themselves, their mental health goes up as well. Why would that 5-year-old child not want to emulate what their granny's achieved? So I hope that was a useful introduction into the Insight report. There will be much more detail to come. I appreciate there's probably not time for questions now. If you want to email me about the research, feel free as well. And thank you very much, Liz. I'll hand over to you.
Yeah, thanks, Robin. And promise me I didn't make him use my last quote there. But I am a granny and I do try and be a good example to my grandson. So, and you just reminded me of that. I think the key messages there for me was I'd never heard the expression obesogenic environment. And I think it's a good thing for us to all think about, Robin. And the bit about starting well in life and, you know, addressing any issues before the age of 5 was really important for me in that session as well. So really good to hear the other bits that the senior leadership people in our system are really wanting to get behind this project, and how important that connectivity and joining up with all the relevant leaders is so important. Now that brings us 3 minutes early to a 5-minute break. So we'll give you a 8-minute break. I can do the sums, and we'll come back at 3:20. And I hope that of the 214 participants that we have on this call will join us back. So we'll start at 2:20 on schedule, and we'll have the panel then. So please have a wee break, and we'll see you soon. Right, welcome back everyone to the second half of the session. So I'd like to introduce Louise Marshall, and she'll introduce the panel members, and she's going to lead the panel on thinking differently about health and obesity. So over to you, Louise, to take control of the panel. Thank you.
Thank you so much. Thank you so much for inviting me to speak today and share this session. I'm really excited by all I've heard so far today and looking forward to the discussion. I'm Louise Marshall. I'm Senior Public Health Fellow in the Healthy Lives team at the Health Foundation and a public health consultant. So here we go, buttons moved on. So as an organisation, our aim is better health and healthcare for all people in the UK, and our Healthy Lives programme of work focuses on the wider determinants of health. So this is what we're talking about today and why we really need to tell a new story about health that includes these wider determinants. Right now in the UK, some people are dying years younger than they should. People born and living in the poorer neighbourhoods live shorter lives than those in wealthier areas. And the end of the blue lines here shows for men and women in England how long someone can expect to live based on the level of deprivation of the place they were born. And as well as living shorter lives, people living in more deprived areas also live more years in poor health. The length of time people can expect to live in good health is shown by the red bars on the charts, and you can see that there's an even greater gap here between the end of the red and the end of the blue, which is years of poor health at the end of life, between the most deprived areas, which is the bars at the top, and the least deprived areas, which is those at the bottom. Oh, skipped on too far. So we know that a leading cause of ill health and a risk factor for many of the major causes of illness and death in the UK is obesity. And as we've heard from Malcolm, socioeconomic inequalities exist in overweight and obesity throughout the life course. This chart shows levels of obesity at 4 to 5 years at the top, 10 to 11 years in the middle, and in adulthood at the bottom. People in the most deprived areas are at the left, and those in the least are at the right. And you can see the gradient at all ages. So this is data from before the pandemic, and what's clear is that levels of overweight and obesity, especially in children, have shot up over the last couple of years, and the gap between the richest and poorest has widened still further. So why do these differences exist? Poverty, poor housing, low paid or unstable jobs, transport and food systems, our education, our social connections and commercial activity all impact on people's health, including their weight. These are known as the wider determinants of health, and the ways they affect health are complex, with multiple interlinked pathways. For example, when people are in insecure or low-paid jobs, they may not have the resources needed to afford healthier foods. Constantly struggling to make ends meet causes chronic stress, which can in itself directly harm our physical and mental health. If we're in temporary accommodation with no cooking facilities, we can't prepare fresh foods, even if we can access them. And food banks are having fresh food rejected by people who don't have the facilities to cook them, or who have to mentally calculate whether they can afford the fuel costs of cooking them. But despite compelling evidence about the role of the wider determinants in health, including specifically in obesity, they're often left out or misunderstood in public media and political debate. Through our communications research with the Frameworks Institute, we know that people think about health in highly individualistic ways. They understand it solely as being determined by individuals' behaviours, the choices they make, and by their access to healthcare. Angela has so vividly and movingly described the human cost and the systemic discrimination that result from this way of understanding. And this individualistic understanding follows through to the government's approach to obesity. Earlier this year, we published an analysis of the government's policy approaches to some of the leading risk factors for ill health in the UK: diet, physical activity, tobacco, and alcohol. This chart, adapted from this report, shows different approaches to public health intervention. I'll just explain this very briefly, there's quite a lot on here. So on the spectrum that goes up and down, we have at one extreme at the top, intervention that's targeted at individuals. On the other end at the bottom, we have those that reach and affect everyone in the population. On the axis that goes from left to right, you can map the degree of agency or resources that individuals must have to benefit from an intervention, going from low on the left, where there's very little needed or asked from an individual, up to high on the right, which would mean a person would need to have significant resources, be these time, money, literacy, transport, headspace, at their disposal to benefit. So I've plotted some relevant government policies onto this map. At the high end, over on the right-hand side, we have at the top individually targeted NHS weight management services. So accessing these requires ability to access a GP appointment, be able to take up a referral, have the time to attend classes, and be able to follow the advice that's given. We also, underneath it, have information campaigns. These reach everyone in the population, but to benefit, to change behaviour requires understanding the campaign, being able to access and afford, for example, the healthy foods that are being promoted. And then over on the left at the population end, requiring little personal resource, we have the soft drinks industry levy. The onus here is on manufacturers to act, and by drinking the same drink we've always bought, we'll have a lower sugar intake. So there's good evidence that for these reasons, interventions that require a lot of personal resource, while they're important as part of a comprehensive approach to obesity, on their own are the least effective and equitable, and they can increase inequalities. Our policy review found that for all of these risk factors looked at, the balance was heavily skewed towards individual level interventions and those that needed individuals to take significant personal action. The soft drinks levy is an example of an equitable population level intervention that's been implemented, but the government needs to go much further and tilt the balance to this type of intervention. There are plenty of well-evidenced proposals and strategies and consultation documents, but these are overwhelmingly the things that haven't been implemented. And as Malcolm's also highlighted, the Obesity Health Alliance strategy report, which was part funded by Health Foundation, is a fantastic resource on this. And absolutely essentially, and underpinning all of this, we need long-term cross-sector action on the wider determinants, a true whole systems approach. By doing so, we can increase everyone's ability to benefit from action to reduce obesity. We can reduce the inequalities and opportunities to access healthier options. We can increase people's ability to afford and access healthier foods, to get out in safe spaces and be active by removing some of the barriers to these. We can fix this. We can strengthen all of these building blocks of health. But for this to happen, we need to increase understanding about the role of the wider determinants of health. And we need to work together across the sectors that hold all of these blocks. So I'm so delighted to be joined today by, I'll leave these actually, these just flagging a few resources that we have from Health Foundation that I've referenced in the last few minutes. So this is our work with the Frameworks Institute. We have a toolkit coming soon to support people talking about the wider determinants of health in ways that help people to understand their role and hopefully therefore support action to improve them, to address them. And then these are two reports, the one with the Frameworks Institute, the one on risk factors, and also our evidence hub, which is a source of evidence and charts and data on the wider determinants. I can share links to any of those if that would be helpful. And so I am really delighted to be joined today. Oh, I've skipped on too far. Sorry, by 4 people from diverse sectors who are doing just this. They're working together and they're working across sectors to improve health and reduce obesity in Cheshire and Merseyside. They are Bronwyn Rapley, CEO of Onward Homes, Barbara Wade, LTP Development Manager at Mersey Travel, Melissa Crellin, Director of Strategy and Public Affairs for Cheshire and Warrington Local Enterprise Partnership, and Margaret Jones, Director of Public Health for Sefton Council. Thank you all for joining me. I would dearly love a whole afternoon to speak with you about this, but we have 20 minutes. So I'm going to dive straight in, and I'm afraid we're going to have to keep to quite brief answers, but I hope that this will stimulate ongoing discussions among people attending this afternoon. So my first question, which I'll go in turn to Bronwyn, Barbara and Melissa, is what is your organisation currently doing or planning to do to help facilitate better health and well-being with local populations? And does any of this work specifically and explicitly address overweight and obesity. I'll go to Bronwyn first, please. Just wondering if there's a way we can.
Forgive me, there we go. Start again. Thank you very much.
Thank you.
A couple of things that I think it's worth mentioning from a housing perspective. I think the first is the quality of good, warm, safe, secure housing. That's obviously where most of my focus is, and we recognise that that's quite a significant part of the wider determinants of health, although perhaps less so about obesity, although if you are in a home that you're not comfortable in for whatever reason, I can certainly understand, why that might make tackling any health problem more difficult. But the other and perhaps more relevant thing that we do is we do a lot of work in and around food security. So one of the things that Onward has done is partnered with an organisation called Community Shop. And in 3 areas across the Liverpool City region, we now have a social supermarket that gives access to low-cost food. It's access to about 30% of the retail price. But tied in with that is a community kitchen, a community hub. And effectively what we recognise is that if we can build on people's own capacity to recover, to deal with a downturn in their lives, to manage their lives, then that's one of the best things that we can facilitate. So our work is on making sure that the properties that people live in are good properties to live in. The other thing we do is quite a lot of work around supporting people with income challenges. So again, that goes to their ability to buy food, and then this very specific work that we do around food security.
Thank you. A really broad range of approaches there. Barbara, can I come to you next?
Yeah, sure. Obviously, as a public transport provider primarily, Merseytravel, backed by the LCR Combined Authority, is promoting health and wellbeing and equality through our corporate plan. So we try to embed health, wellbeing and equality in all our policies. The area I particularly look after is active travel and active travel development across the Liverpool City region. So we've got a local journey strategy which focuses on trying to encourage walking, cycling and wheeling for those local journeys, recognising of course that there are some journeys that just need to be done by private vehicle or by other methods of motorised traffic. We promote a infrastructure plan which has got it's a 10-year plan and looks to build out 600 kilometres of safer, more attractive routes for cycling, walking and wheeling. We have adult cycle training that's available because we're trying to remove some of those barriers that stop people from accessing particularly bikes and thinking that they can't do it because they weren't very good as a child or never had their cycle proficiency as a child and stuff like that. So we try and tackle those barriers as well. We all obviously go into schools and do that cycling proficiency, which is now called bikeability, for those of you aren't as old as me. We encourage, and we've got some money from Department for Transport to look at implementing school streets. So that's about taking those everyone's aware of the school run and the pressures of parking around schools and the air quality problems that creates, where we've got our little people gathering. So we try and encourage people to park outside of a certain area by a school, so that there's that walking element that has to then be done, and that comes back to embedding that in our children and our grandchildren, those kind of activities. It's perfectly acceptable to do and good to do. We run behaviour change campaigns. We've also started working with Sustrans and are trying to promote in 4 locations across the Liverpool City region the idea of livable neighbourhoods, low traffic neighbourhoods. So again, just to not anti-car by any means, but just trying to make it much more attractive for people to use active modes for those short journeys, rather than just jump in the car to go to the newsagents, which is 5 minutes down the road. And all of this, I suppose, is recognising that it's about that wider, you know, life-changing elements. It's not just about walking and cycling. It's got to be part of that bigger, you know, lifestyle change. One of our big projects, which Margaret probably knows more about than me, is we're waiting for confirmation from DFT as to whether or not we've been successful with a pilot study to promote active travel GP prescribing. So, and again, that's just about that encouragement, and that, as I say, Margaret will know more about this than me. She's been much more closely involved, because one of the areas is in Sefton, and we're looking to, again, provide access to facilities and trying to remove barriers in the local communities that would stop people thinking that you know, well, I can't cycle, or you know, walking's not for me, and just those kind of activities. Really, we do a lot around air quality as well, which is not necessarily focused on people living with obesity, but it's about health issues, recognizing that transport is one of the major impacts of poor air quality in our region. So yeah, could go on and on, but I won't.
Thank you again. I'm just really struck by how broadly you're thinking about this, and how many kind of prongs there are to your approach and how it's joined up. And yeah, we have recently introduced school streets at my daughter's school, and I cannot describe the difference it has made to the school run and the lowering of my stress levels, apart from anything else.
Excellent.
Can I put the same question to Melissa, please?
Thanks, Louise. So I work for Cheshire Mornington Local Enterprise Partnership, and our new vision post-pandemic is for a healthy, sustainable, inclusive and growing economy. So we work with partners and stakeholders to plan for a better economy. We recognise the link between ill health and lack of work and poor quality work, which you spoke about in your presentation. So we also recognise how that leads to social exclusion and work exclusion, and the links between ill health and areas of deprivation. We at the LEP have got the role to deal with work and economic issues. We see that also as encouraging employers to go further in providing good and fair work. That could be paying the real living wage, providing for employees' mental and physical health. And we need to ensure that we're providing support to people in who need that support in terms of levelling up, people with the barriers to inclusion, those on free school meals, the long-term unemployed, and that kind of thing. We do have a commission set up at the moment called the Sustainable and Inclusive Growth Commission. The Leaders Board set that up made of independent commissioners to advise on going further and faster to create that sustainable and inclusive economy. So within inclusive, that refers to health and work issues as well. So we also, one of the major things that we're looking at doing is developing a good or fair employment charter. Liverpool City Region already has one, which they have sort of launched recently. Greater Manchester also has one. So we're looking to do that as well and provide that sort of parity. It's basically would address a lot of the issues around poor quality work and around recruitment to get more diversity into people into work, getting secure work, flexible work, better pay with the real living wage, making sure people have engagement and voice, more health and well-being. So, you know, it's helpful that other health colleagues deal with the mental health, but we can try to get employers to recognise those issues as well. And sort of to do with motivating and training staff and making sure that there is that understanding. And I think it's all very interrelated. We've also, you know, within our commission, there's lots of other areas to do with transport and that kind of thing to do with active travel. Just recognising the importance of making sure that everything's joined up and that we're working together to share best practice.
Thank you so much, Melissa. You know, I will say the same thing again. I'm so staggered by how broad the action you're taking is, and how you really understand the breadth of your sector's impact on health, and you know, the potential impact you can have in improving health, but also in a true sort of complex systems way, and understanding the sort of intended and unintended consequences and the places where things intersect. So thank you for describing that. I have a question to Margaret now. So we've heard this really clearly from three panelists so far, but I wondered if you could briefly talk a bit about the kind of other organisations and the breadth of organisations that your council works with in your approach to reducing overweight and obesity. Next question to Margaret, please. Yes. Hi, Margaret, can you hear okay?
Hi, Margaret, can you hear okay? I can hear you now, thanks, Louise.
Just got a bit of a delay. I think that's better, and I can see you on my screen now. I'll repeat that question. And I wondered if you could please, so we've heard, things from Bronwyn, Barbara and Melissa. And I wondered if you could speak about the kind of wider organisations and sectors that your council's working with in your approach to reducing overweight and obesity.
Yeah, so it's really important to stress it's a multi-agency approach. You know, statutory organisations, but also the third sector are really important in this as well. So in Sefton, we have a healthy weight declaration, which we first signed off in 2017, and obviously with the impact of COVID, we've been looking at, you know, how we're actually working together, and we're refreshing that at the moment. So it's a key priority. It's part of it's one of our 3 priorities as part of our place priorities as part of the new integrated care system approach to working together. So, you know, we're looking across a range of interventions, from things like planning, economic regeneration, hospitality. So we're looking at access to food availability. The wide determinants is obviously really important, because one of the biggest challenges we're all facing now is the cost of living and the poverty and the impact they're going to see, you know, as we go through the year. So with increases in fuel prices and how that's going to impact on people's food choice. So it isn't just about the NHS or specific local authority services, it's everybody working together really. So if I sort of unpick some of those things, because I realise that's a huge agenda, we can't do it all at once. We have to do a bit at a time really, and we have to be realistic. I think it's been stressed already. We didn't get to the figures we've got around overweight and obesity overnight. It's taken a long time, and it's going to take us a long time to reverse some of those trends. So if we're looking at something like you know, food choice and food availability, then one of the things we're working with is working with our school meals providers, and looking at, you know, can we have a agreed standards for school meals and improve the choice of food in schools, but also can we work with our partners who support children and young people, can we look at access to food outside school, you know, the journey to school past the takeaway premises, what's influencing food choice, can we use planning restrictions, for example, and we've looked at in Sefton whether we can restrict takeaways within, you know, a certain distance to schools. So again, it's about trying to create environments more conducive to people having a healthy diet, having a healthy weight. Other things that we're looking at is, you know, for a borough like Sefton, tourism is really important, events is really important. We know that food we do eat for pleasure as well. Sometimes we forget that in these conversations, that people eat because it's a social event, we go out, we enjoy ourselves. So it's about, you know, how can we work with the hospitality industry? How can we work with event planners that we at least have options for healthy food that can at least encourage, you know, simple things like having free water on tap at events, so that, you know, it's not a cost burden to families. And so again, it's about trying to make things as healthy as we possibly can, but without I think without restricting people, because that's the other thing. We need to take people with us as well. We need to, going back to that message before, it's about a healthy choice, a positive choice, rather than always being negative, and encouraging people and not blaming people or stigmatizing people. I think that's obviously another issue that's really important to us.
Thank you, Margaret. That's fantastic. I wondered if there were any sectors that are sort of in your sights that you would like to engage on your approach to overweight and obesity, but for whatever reason, you know, haven't at this stage.
We obviously want to work with employers and, you know, improve food choice, improve, it's not just food choice, but if we think about, you know, the hours that people work and the breaks that people have, transport to work, and there's lots of, you know, there's lots of big, medium-sized employers we can work with, but I actually think that, you know, for us in the councils and in the NHS and all the statutory organisations, we need to put our own house in order as well. We need to think about how we make it easier for our staff to walk to work, to, you know, to move around and be active when they're in work. You know, do we have you know, access to health food for patients, staff, visitors, and that's the same in the council. So I think it's something that we could all be better at. We could all, you know, make improvements there.
Thank you, Margaret. That's oh, sorry, I'm cutting off. Thank you so much. I have 2 more minutes that I wondered if I had time for a very, very quick round of questions from Bronwyn, Barbara, and to Melissa. So you clearly all really well understand the potential impact of your sector on health and obesity. I wondered if that was common amongst colleagues in your sector, or is this sort of specific to you as individuals maybe who are engaged with this topic and this agenda. So I'll go around again just to Bronwyn first, just with very quick answers in the last couple of minutes.
I think I would say as a sector, we're very clear about the impact of poverty, less so about the impact of obesity, often very tied together, as we've heard today.
Thank you. And Barbara?
Yeah, I think we're very focused on health and well-being, as I said, in the transport sector, and we recognise also that there's such a thing as transport poverty. So, you know, public transport can often be very expensive. So again, that's where my role as promotion of active travel, just walking, you know, it's not expensive, but it can get you to those short journeys. And if I could be cheeky and just say that we would love to work with health colleagues a lot more in public health, because we feel that in some areas, particularly areas like this, we all want the same outcomes at the end of the day, but we often don't, you know, if we can pool our pots of money, I think we might be able to achieve better things. So that's my answer.
Great. So hopefully something that can come out of this. And then finally then to Melissa, please.
Thank you. I think, yeah, when you look at local enterprise partnerships in particular, there's been a lot of focus on sort of skills and helping people who are unemployed back into work. But the sort of focus on health and understanding the wider systemic approach is possibly a little bit newer for the sector post-pandemic. So it's something that I think most LEPs are grappling with at the moment, and it's something that is rapidly developing. I think where you've got combined authorities and LEPs together, they've possibly got more resource and are more able to kind of join these things together, because LEPs themselves are fairly small. But yeah, I'd say it's moving fast at the moment.
Thank you so much, Melissa. And sadly, we're out of time. I'm at time. I could speak to you all afternoon, but unfortunately, I have to hand back control to Liz. So just a huge thank you to all 4 of our panelists this afternoon. And again, a thank you for inviting me. It's been a really interesting afternoon.
Thanks, Louise, and many thanks to all the participants in that panel, again showing the importance of everyone's involvement and joining up all the different agents that can help tackle this problem. So we'll move swiftly on, and I'll introduce Dr. Ian Jarman and Dr. Philippa McCabe, and they are from Liverpool John Moores University, here to talk about data and mapping. Sounds very clever. So over to you both to talk to us now. Thank you.
Thank you. Good afternoon, everyone. I'm Dr. Philippa McCabe, and I'm a postdoctoral research assistant within the Data Science Research Centre at Liverpool John Moores University. Myself and Dr. Ian Jarman, who isn't available today, unfortunately, have been working on this analysis for the past few months. And today I'm going to give an introduction into the new data mapping that we've been working on around obesity, cancer and deprivation within Merseyside and Cheshire. So let me just... There we go. So the whole aim of this work was to investigate some publicly available health data. We wanted to use this to investigate relationships between deprivation, cancer, obesity, and other social determinants of health. One way we chose to do this is with the statistical mind map to further understand the pathways and correlation structures between those features of interest, such as obesity, specific cancers, and deprivation, just to name a few. So to do any analysis, we need data, and then the choice is what data do we use? Well, any data scientist would say that the more data that we have, the better. So we started to look at how we can divide England into different little subcategories, into different sections. So for any given region, we've got kind of clinical commissioning groups, or we did until that got changed, GP practices, primary care networks, local authorities, electoral wards, and then MSOAs and LSOAs. So within Merseyside and Cheshire, the divisions we've got, which we've looked at, is 9 clinical commissioning groups, 9 local authorities, 34 primary care networks, 324 MSOAs, and 353 general practice surgeries. So what we found there was the more that we zoom in, the more information becomes available. So to visually represent this, we've got 2 maps of the sub-region. So the visual representation on the left, the CCG one shows 9 CCGs. And then if we split that up into electoral wards for the exact same region, we get 245 wards. So we go from 9 pieces of data to 245 just by changing the kind of group we want to look at. So taking this into account, we've decided to use data from GP practices. Oh, gone too far. Oh. There we go. We've decided to use data from GP practices to form the basis of our analysis. This is due to the fact that we've got more data being available and collected across different areas, so we can have a look at a detailed view of the disparities within the sub-region. So the GP data has over 250 variables, and these include things such as long-term health conditions, heart disease, kidney disease, cancers, and then we've got antibiotic prescribing data, so how much is prescribed per broad spectrum antibiotics, and then specific kinds. And then we've got maternal and child health, just to name a few. And we've narrowed all those 250 variables down to 48 for our analysis. And those were selected based on a variety of health themes, including social determinants of health, so things like smoker status, employment, deprivation. They were the driving features behind what we've chose to look at. So As we've heard from many of the presentations, if not all today, deprivation is a key driving influence into health outcomes such as cancer and obesity. With that, I thought it might be useful to have a little refresh of what the index of multiple deprivation is. So that is a measure that was created to sum up 7 different domains, such as, well, they are income, employment, education, health, crime, barriers to housing and services, and living environment. So from this point forward, when I'm saying deprivation, that's the broad spectrum of things I'm referring to. So skipping ahead to the end before we actually do get there, I'm going to see where deprivation fits within the other features that we want to look at. And when I say fit, I mean statistically fit. And this refers to not causal, we're not looking at causal links, we are only looking at statistical links. So these are statistical associations shown within the data that we will see again at a larger scale at the end of the presentation. So deprivation is linked in each feature on this diagram, meaning that there is a statistical association. So obesity, screening for both bowel and breast cancer, which I'll come on to shortly, life expectancy, mental health and unemployment are all statistically linked to deprivation. In particular, we'll come back to the relationship between deprivation and life expectancy in a moment. But deprivation, from what we can see here, is the driver in many problems that we've got in society to do with health. So we've covered the background, so now we're going to look at a couple of separate pieces of information on their own and see what they can tell us about Cheshire and Merseyside. So here we've got a histogram showing the deprivation scores for the sub-regions GPs and how it compares to the national average. The red line is showing the national average for the deprivation scores within the UK, which is set at 21.7%. Most of the data that we've got for the GPs within the sub-region falls above that national average. So we've got 64% of GPs having a higher deprivation score than that national average of 21.7%. And this is a finding that is very relevant for the wider projects ongoing with this work. So back to that relationship that I mentioned before, deprivation and life expectancy. We know that the more deprived an area is, the lower the life expectancy. The data from Cheshire and Merseyside is no different, so we can see that with this diagram. By highlighting the CCG points on this plot helps to show how different areas fit in within that graphical representation. So we're going to focus in on Cheshire and Liverpool specifically to emphasise the differences between life expectancy for those in more and less deprived areas. But before I move on to that slide that just shows those two, if we look, we can see there Cheshire and we can see there Liverpool based on that colour scheme. So if we remove the other points, we get this diagram. So this shows us exactly the same thing as what we see before, but we can see that they are two contrasting areas, with Cheshire on average being a more affluent area. We can see exactly that with what we can see here, that the bulk of the points for Cheshire are sitting at the top left corner, whilst Liverpool's are more spread out, but mainly towards the bottom right. This is emphasising that the more affluent Cheshire has a higher life expectancy than the deprived areas of Liverpool. So changing focus now to one of the other features that we wanted to look at, which is obesity. Research has shown that obese children often become obese adults. Therefore, we thought it was important to see how the children in the sub-region compare nationally. First off, let's look at reception. The prevalence of obesity spans from less than 5% to around 20% within Merseyside and Cheshire. The national average is set at 9.7%, which means that 62% of areas have an obesity prevalence in reception-aged children that is higher than that national average. So the same can be said for Year 6 children. This time, the range of obesity prevalences goes from less than 10% to more than 30%. This is almost double what we found for reception year. Despite the national average being higher, which is at 20.4%, there are still 46% of areas with an obesity prevalence in Year 6 children that are higher than this national average. Again, this finding is something that's relevant for the ongoing work that we're doing. So knowing that the link exists between obese children and obese adults, it is unsurprising that within the sub-region, 59% of GP practices have an obesity prevalence higher than 6.9%, that national average. And the maximum value within the Cheshire and Merseyside region is nearly 3 times that national average at about 20%. And this finding is also one that will be useful going forward with this work. There we go. Cool. So having looked at deprivation and obesity individually, we wanted to assess if there was a relationship between the two. And we can see from looking at this plot, as deprivation increases, so does obesity. So we can see that there's an overall trend in this direction. Now, these two lines that form like a funnel show us that as deprivation increases, so does the range of obesity values. So for low deprivation, there are only a few obesity values present in the data. So we can see that they're all clustered in this sort of area. And then for the higher deprivation values, we get a wider range of obesity values being present in that data. And again, we can see where the points for Cheshire, which are those red points, and Liverpool, which are those green points, are sort of separate, and they are distinctly different on this graph. So if we look at those two areas on their own again, we can see an affluent area, Cheshire, has all the points clustered together in the lower obesity range, whereas Liverpool, an area with a wide range of deprivation, and some areas that are falling into that affluent group, have a wider range of obesity values as a result. So they're spread out and encompass, and Liverpool sort of spreads out and encompasses a wider range of values, both deprivation and obesity, which we can see in that diagram there, that graph. So we've looked at deprivation and obesity, and now we're going to shift focus one last time and have a look at cancer. So within the sub-region, around 63% of GPs have a higher cancer prevalence than the national average of 3.2%, with some surgeries reporting a prevalence of as high as 6%. This is nearly double that national average. As cancer prevalence is covering all cancers for all ages, we wanted to look more specifically at different kinds of cancer, such as bowel and breast cancer. Now, given that the focus of publicly available data doesn't always fit what we would like to answer, and the information that is available publicly is limited, we thought that focusing in on those two particular kinds of cancers wouldn't be possible, specifically the cancers alone. However, what we do have information for is screening for breast and bowel cancer. So we thought that would be a useful link. So we focused in on those. So within the sub-region, uptake for screening is lower than the national average for both breast and bowel cancer. And for breast cancer, 64% of GPs report lower than national average uptake within 6 months of invitation. And bowel cancer screening has 59% of GPs with a lower than national average uptake. So given that the population for screening for both breast and bowel cancer are different, so we've got breast cancer screening only targets females, and male cancer screening targets both male and female, is there a relationship between the two? Well, the short answer there is yes. We can see that as the uptake for breast cancer screening increases, so does the uptake for bowel cancer screening. And we can see that with that trend going through there. So in a similar way to what we looked at earlier, we can see how each of the CCGs fit within this graph and the data spread. So for the last time, let's focus in on Liverpool and Cheshire specifically. So like in the previous comparisons with Liverpool and Cheshire, the two CCGs are easily separated. So we've got Cheshire, which tends to be a more affluent area, like I've said. We've got uptake for both screening types, high, versus the more deprived area in Liverpool, which has lower uptake in both screening tests. So this is also emphasising how deprivation contributes to factors that can influence health, such as cancer screening attendance, which is a useful way to detect cancer at an early stage. So we've explored several features by looking at one or two on their own or as a pair. Now we're going to attempt to look at all the features together to see what, if any, relationships are present. Now, just a reminder, when I say relationships, I am only referring to statistical associations, and I'm not on about causal links at all. So this type of map that we can see a diagram version of is called a conditional independence map. We can think of this like a statistical mind map. So in this example, we can see how obesity is linked to these other features, such as alcohol, physical activity, and diet. They can then be used to determine what interventions can be put in place. And then for the contextual features like age, although we can't actually change age, we can influence the services within that community. So these kinds of relationships could spark conversations that then could influence further research that might then introduce policy changes or education or something like that, that could then have an overall impact on those features. So now we know what they are, we can now think about how these maps can actually begin to help. The maps take in a wide selection of public health data, and from this we can then develop that statistical mind map to gain insights into the pathways and relationships in the data, which can then be used to support data-driven, evidence-based decision making. So using our GP practice data, we've made two maps, the first being with breast cancer screening, and then the one I'll show in a moment will be bowel cancer screening. This shows that the data is linked and how they're all statistically connected. On this map, we can see two main themes. So we've got the community and social factors, and then the factors related to getting older. The main thing that we wanted to focus in on was the community and social factors, so let's zoom in on that. So we can see clearly that obesity, breast screening, and deprivation score are all directly statistically linked. They're also highlighted as they were features of interest for our analysis. Deprivation is also statistically linked to unemployment, mental health, life expectancy, and a contextual link is epilepsy. This would provide a starting point to then explore these individually, moving into a deeper analysis. And again, we have the same themes at play, considering bowel cancer screening. So we've got those community and social factors and those factors related to getting older. And once again, we can see that obesity, screening, and deprivation score are the highlighted points and the focus that we want to look at. So zooming in on those community and social factors one last time. Again, screening, obesity, and deprivation are all directly linked, which imply relationships between these features. But we all know for certain, all we know for certain is that the links are statistical and not causal. Once again, deprivation is statistically linked to several features like unemployment and life expectancy. And this is the relationship that we explored earlier in those earlier slides where we looked at Cheshire and Liverpool separately. So through deprivation, many features are linked, which can lead to the conclusion that what you do and where you live can and does influence your health. So from all of the data and the graphs that we've shown, we can see that deprivation is the main driver that links obesity and cancer screening and is the bridge to several social determinants of health. Following on from this work, a full report detailing all of the analysis that we've done, along with the maps, will be looked at in more detail, which will be available in August. Thank you.
Thank you, Philippa, for sharing your knowledge of data science. That was very helpful in understanding all the links that we've been talking about this afternoon. We'll move on to Dave Sweeney. I see you're in the room now, Dave, and you're here to talk about, the role of the health and care sector, taking a whole systems approach. So over to you, Dave. Thank you.
Hi, Liz. Thanks very much for having me. Apologies for being only joining later on. It's been one of those days. How long have I got, Liz?
You've got 10 minutes and I'll come back on screen. I'll give you a 1 minute warning.
Not a problem. Okay, so I'm really privileged to be here, actually. I think what Philip has just shown us that we've got a bit of a mountain to climb, actually, in terms of that research. For those who don't know me, I'm Dave Sweeney. I'm the Associate Director for Partnerships and Sustainability. I've been around Cheshire Merseyside for quite a while. A really varied background, but mainly from a partnership perspective, I kind of like to think of myself as a bit of the Kofi Annan of healthcare and partnerships, because what you just heard from Philip, it takes partnership and collaboration, and it takes bravery, and it takes us to do stuff. And I think with one of the things that Philippa's session just sparked for me was this may change policy. I agree with that, and I think we do need that kind of central role. But actually, as we're moving through into this new world of integrated care boards and integrated care partnerships and collaborations, we can just get on with it. I mean, that's the top and bottom. We shouldn't have to wait for central government or central NHS to dictate or to mandate what we're going to do. The problem is on our doorstep, and it's getting worse. And there is no doubt about it that the opportunities are there. So my role in terms of sustainability, there's so many links here. There's so many links. I mean, we're fighting. I know Mandy's on this call. Mandy Craig, she's been fantastic. She's part of my team. And we've got all 17 trusts lined up, NWAS and various other organisations, the starting point of their green plans. So each of those organisations have developed a green plan. And the reason I'm kind of concentrating on green, because if we haven't got the parks and the spaces and the green, open and clean air, then we haven't got anywhere for these kids to get out and kick a ball around, or just do what kids do. And I think the starting point, there's so much evidence now. We are so evidence rich that it's about getting on with it now, I have to say. And from our perspective, and certainly from my perspective in this, there is no better time. There are so many things that you can layer over this that are already there from a national policy perspective. Cheshire Merseyside are now a Marmot site. So the Marmot report is out, and working with Sir Michael and his team, there are some really simple things that we can do if we collaborate together. And in there, we've got a marked priority there in terms of green and the green agenda and environmental sustainability. And then you overlay core 20+5, and again, riddled in Philippa's data there is that demographic, is that poor demographic. And I kind of don't know about you guys, but I get a little bit tired of the kind of deprivation top trumps. Everywhere I go and speak, it's almost like people are almost kind of going into the detail of how demographically poor or different, diverse to everybody else. And that we in Cheshire Merseyside, we have a fantastic kind of culture and infrastructure. So I'll give you an example. So when I was the chief officer in Halton CCG, and in that borough was Widnes Vikings. So we did a very simple piece of collaboration where we just weren't hitting home. The white coat scenario wasn't really working in our schools, and so we used the rugby team to go in and to start shifting the culture in those schools, not just necessarily doing the training, but getting into the culture of teachers' heads and the boards of those schools, that this is as vitally important as education, keeping kids fit. We know all the research in terms of how important that is. And it snowballed, it went absolutely crazy in terms of how they bought into it. And I remember I've just been looking through now some old stats, and one of the schools, Holy Family in Widnes, they, rather than employ TAs into the school in terms of education, they employed sports graduates and trained them to be TAs, teaching assistants in the school. And their job through that growth was to train the kids every day, and the kids loved it. And I can't remember the original stat, but it was something about 18% of the school was obese. And in the first year, they got that down to 3%. And the year after, there was zero obesity in that school, in that complete school. And they used the walk, they used the mile a day thing and all the rest of it. And I don't hear much about it now. It seems to have kind of lost its way a little bit. So that in terms of sustainability, when you look at all this, it's almost kind of crisis stage. And we're pushing Graham Irwin, who's our new chief, and Raj, to signal that climate crisis, because that's exactly what we need to do. So recently, this week, we just signed off. This is really important for people who work in various trusts or various local authorities and what have you. We just signed the Anchor Institute, the Anchor Charter priorities. So for organisations to be an anchor, prevention has got to be at the heart of what they do. They've got to be looking towards a minimum wage and paying minimum wage. And again, if you see in those stats what Philippa said, in terms of those areas of deprivation, it's too easy to say, go and eat fruit and veg and do, and exercise. It's too easy. It's that debate has gone. We've got to be really different and dynamic and brave in terms of of how we go about this. So the long and short of this is that every organisation in Cheshire Merseyside will be an Anchor Institute. I have no doubt about that, because it's the moral and socially right thing to do. So within that, at the heart of that, it's ensuring that our kids and our kids' kids grow up with a planet. It's almost a kind of a mute debate if we just let the planet die around us. But more locally to that, ensuring that any good idea, and I can't emphasize this enough, any good idea should be pinched with pride, nick it, install it, and get it into your place and make it work. We've been far too parochial over the years, way too parochial. We don't do it here, we do it this way in this borough, we do it this way in that. We need to get the best resources, the best ideas, and spread them right across Cheshire Merseyside. And my plea is, let's not please wait for national policy or a mandate from government or from central NHS to actually improve people's lives, because that's our moral responsibility and our jobs. And it's the reason that we all get up in the morning and do what we do. So I'm really keen, in 10 minutes, I can't really go in through the whole spectrum, but I'm really keen to connect. Mandy's on this call, Mandy Cragg, who's absolutely superb and knows literally everything about the environment and sustainability. And I like giving myself actions as well. So from today, if there's 4 or 5, 10, 100 connections that we can be made and sharing good ideas, it's a step in the right direction. And I'd be really pleased to play a massive part in that. So I'll end there, Liz.
Thanks, Dave. That was a real call to arms for everyone. And Mandy's put some information in the box, so thanks for that. I think you also gave a really good example of trying to get kids to start well in life. And that was a strong message there. And I think don't reinvent the wheel, just get on with it, was your proper message right at the end, and totally agree with you on that one. So many thanks, Dave, for coming on the call and sharing your experience and your enthusiasm for tackling this issue. If I now hand over to Matthew, who's the Exec Director for the Health Equalities Group, and he's going to talk us through next steps and a call in the same spirit of doing something, or just do stuff, as Dave said, a call to action for all stakeholders. So over to you, Matthew. Thank you.
Thanks very much, Liz, and thanks to Dave previously as well. Pinch with pride. I like that, Dave. I think that we certainly intend to do so over the course of the next few years with this project. My name is Matthew Philpotts. I'm Executive Director of Health Equalities Group, and with the public health charity that runs the Food Active programme, something which many of the folk on the call today are probably familiar with. We're a collaborative programme launched by Northwest DPH's back in 2013 to address this increasing level of overweight and obesity across the region. We don't really work directly with individuals around behaviour change, but we're looking to work around population level policy changes and interventions that address those social, environmental, economic and legislative factors that can then affect people's ability to change their behaviour. So the pithy phrase that we come up with is less about victim blaming those individuals. It's much more about environment framing. So trying to address this obesogenic environment through legislative, economic and environmental levers. And I have to say that we are delighted to be assisting the Cheshire and Merseyside Cancer Alliance in development and delivery of this new system-wide project to address overweight and obesity. So many thanks to John Hayes and his team, in particular Steve Jones, in terms of the work that we've been able to co-develop to date. So in terms of this project, I think John's mentioned some of this right at the top of the piece today, but essentially, what are we trying to do more than anything else? It's establishing the reduction of overweight and obesity as a significant agenda item. And that's for all stakeholders across Cheshire and Merseyside, including patients and the public. This is everybody's issue. It's really a case of making a reduction in obesity everybody's business. So we've got to take this outside of local authority public health teams, certainly outside of the NHS. Going back to our panel session before, yes, this has to be about transport, about skills, about living wage, about active access to green space. So today we're launching this new network for Cheshire and Merseyside, and we're basically trying to reduce overweight and obesity and also raising awareness of obesity as a risk factor for cancer. The idea of this is not to replicate what is going on at place level or at local authority level, but to do this interconnecting, to galvanize this work, to basically increase the overall volume and reach of policies and interventions across the sub-region. So our approach, well, we've heard about quite a bit of this today, or at least I hope that we've put a little bit more substance together in terms of working with a cross-section of stakeholders from both health and non-health backgrounds. So we need to really work with them and for them to deliver in terms of shaping this agenda and delivering on objectives. So there's a really strong focus on both the economic and social determinants of health and how they contribute to overweight and obesity. So that's around transport, around access to employment, around access to fresh and healthy foods, trying to eradicate these food deserts that are all too prevalent within some of our areas. It's around employment opportunities and around living wage that Dave's just mentioned as well. Access to green space, about active travel infrastructure, and most certainly around what we can do with current levers, such as planning restrictions in terms of curbing the prevalence of hot food takeaways. And of course, we want to do an awful lot more work in terms of curbing marketing of products that are high in fat, salt, and sugar. As we've heard already in a number of the presentations, probably every presentation, I think today, deprivation is something which is an absolute key driver. It is the main driver in terms of some of the problems that we are facing in terms of the increase of obesity and overweight within our populations. So quite clearly, there's going to be a very strong focus on populations and geographical areas that are suffering higher levels of deprivation. So what's up next in terms of this project? You've already heard from Robin today in terms of this first wave of stakeholder interviews. We're going to be having a second wave, which is going to be focusing on the voluntary sector, on large employers. How can the private sector play a really formative role in this? And we're going to be talking to other stakeholders such as planners, how they can affect things as well. So we're going to be having a final report on this second wave of interviews at the end of November. The data analysis that you just heard from Philippa, we're going to be having a report on all of that work and how those data maps can then start to work with some of this qualitative work by the end of August. And then across October to December, we're going to be piloting some weight loss interventions, and we're looking to engage large employers for delivery of a staff-based weight loss intervention. And that's probably going to be focusing on routine and manual labor occupations in areas of higher deprivation. But most importantly, how can you contribute? How can the people on this call today and all stakeholders across Cheshire and Merseyside play a formative role in this network? Well, we're going to be having future network meetings, the next one in October and another one in February. We're planning to have an annual conference, possibly even face-to-face, who knows, each summer over the years ahead. We're looking to form some expert subgroups. So subgroups that perhaps are probably going to be focusing on physical activity, childhood obesity, around marketing of junk food, and also a patient public focus group as well. And we'll be sending details about these and how stakeholders can sign up and become members of these subgroups in follow-up to this meeting. There'll be a large public consultation process, which is kicking off next month. That's going to be both an online process, and we're going to be holding 4 face-to-face consultation events across Cheshire and Merseyside, 2 in Cheshire, 2 in Merseyside. Again, further details of that and how people can participate and be part of those consultation sessions in follow-up to this meeting. And finally, from November onwards, we're going to be having a digital presence for the network, and we're going to be rolling out the first wave of a social marketing campaign. And again, a lot of that consultation, Robin talked about this a bit earlier actually today. How do we best communicate this? How can we use the vast amount of expertise and lived experience out there to help shape these messages as part of the social marketing campaign? We're all going to be wanting to work with you on that. And again, further details to follow up in terms of the follow-up message from this meeting today. So that's it from me. We hope you enjoyed the event today, and we hope that you've taken some inspiration from it. I think it's my point now to actually thank Liz for being a fantastic chair today, and a very safe pair of hands in terms of keeping us to time and also to be able to just make things run smoothly. So huge thanks to her and to all of the people who've contributed, both in terms of speakers, panel members, and delegates who've joined us today. It is the start of a journey, but I really think that actually we can really make a mark on this as a sub-region. There aren't actually any other cancer alliances doing this type of work around overweight and obesity. So let's lead the way. We have got some very significant problems that we do need to start to really drill down into and start to galvanize support. But hopefully this can be the start of a positive journey. Just to let you know, all of the slides and a recording of this will be sent around to all of the delegates today. But I'm just going to hand over to Liz just to sum up with and a few final thoughts. So many thanks again, Liz.
Thank you, Matthew, and very clear about next steps, and we want to keep that momentum going. If I just pick out a few key things from the whole afternoon, I think the first thing is the importance of tackling that obesogenic environment and areas of deprivation from which we've seen lots of variation through a multi-agency approach. I think the value of data science is invaluable in helping us drive the change and influencing policy, which is also important. I think in the heart of it, particularly from the lived and experienced story, there's individuals at the heart of this. There's people there, and I think taking the individual approach to helping them improve their health is important as well. Starting well, we've seen the importance of starting to shape people's behaviours early in life is important. And finally, let's not be judgmental and to use the momentum we have here to do something now. So thanks for your engagement and for many of you for staying the whole afternoon. And thank you for your time and attention. And of course, thank you to all of those who contributed to the afternoon. Thanks very much. Bye-bye now.
Thank you, Liz. That was fantastic.
That's fine. We kept time, so that's great. And I think all the speakers were excellent at keeping to time. So for those of you on, many thanks as well. We'll be in touch, yeah?
Thanks a lot. Yep, will do.
Okay, bye now.